Hi, my name is Carolyn Calfee, and I'm a faculty member at the University of California, San Francisco, and I'm delighted to have the opportunity to speak today about ARDS. Are we ready for phenotypes? These are my disclosures. So I think we all know that unfortunately the list of tried and tested pharmacotherapies in ARDS is a list of failure. This is just a partial list of some of the many drugs that have apparently cured mouse ARDS and been successful in early phase clinical trials, in some cases only to fail when it comes to large scale clinical trials. So we're certainly ready for more success in the area of clinical trials of ARDS pharmacotherapies. Now, there are many different ways to phenotype ARDS. When we talk about are we ready for phenotypes, there's many different ways to slice that onion. The most clinically obvious are the ones that we've been talking about in many cases for decades: ARDS risk factor, direct versus indirect lung injury, severity of ARDS, diffuse versus focal ARDS, and most recently, of course, COVID-19 versus typical ARDS. And these phenotypes may certainly have great value, and I don't want to discount them. But the primary focus of what I'm going to talk about today is the latent phenotypes that our group has been working on in the past 7 to 10 years or so, that we've now identified in 5 separate ARDS randomized controlled trials shown here on the screen. I'm not going to review that work in much detail today, other than to say that the hyperinflammatory phenotype has consistently worse clinical outcomes, and to say that in secondary analyses of several of these randomized controlled trials, these latent phenotypes appear to respond differently to randomly assigned therapies, including high versus low PEEP, conservative versus liberal fluid status, and pharmacotherapy with simvastatin versus placebo. So the hope is that this approach might be identifying a treatment responsive subgroup. However, all of this work that I've summarized briefly just now is really focused on retrospective analyses, and prospective confirmation is going to be imperative. So what do we really need in order to move towards prospective testing of this approach in randomized controlled trials, or to be ready for phenotypes, as the title suggests? Well, I think there are a number of different key questions, and I'm just going to talk today about 5 of them. First is generalizability. Are these latent phenotypes present outside of randomized controlled trials? Second is feasibility. Can these latent phenotypes be practically and easily identified? Third is specificity. Are these truly phenotypes of ARDS, or are they actually phenotypes of critical illness more broadly? Fourth is mechanism. What are the biologic determinants of outcome in each of these latent phenotypes? And then fifth is approach. How should we think about prospective clinical trials that incorporate these types of phenotypes? Now, I think we have relatively good data now to suggest that these phenotypes are generalizable. We have growing data, but yet not entirely conclusive, that they can be feasibly identified, and some interesting approaches that I'll talk about at the end towards clinical trials. I think we have many more questions about both specificity and mechanism, and I'm going to go through each of these now in turn. So let's start with generalizability. Are these latent phenotypes present outside of randomized controlled trials? Well, so the first group to really address this was the MARS consortium, led by Lua Bos and Marcus Schultz out of the Netherlands, that used an observational cohort and clustered patients using hierarchical clustering of biomarker data only. They identified 2 groups, which they termed the reactive and uninflamed phenotypes. And again, this was an observational cohort of ARDS patients not enrolled in a randomized controlled trial. Now, the overlap with the latent class analysis defined phenotypes that I referred to earlier has yet to be determined, but certainly this data suggested that there were distinct phenotypes of ARDS present outside of randomized controlled trials. Our group has been working on testing the question of specifically whether the latent class-derived phenotypes are present in observational cohorts, and I'm going to show you some as yet unpublished data, work done by Pratik Sinha, who's my former postdoc and now a faculty member at Washington University at St. Louis, and in collaboration with Lorraine Ware from Vanderbilt. We took patients enrolled in 2 large observational ARDS cohorts: the VALID cohort based at Vanderbilt in Tennessee in the US, 624 patients, and the early cohort based at UCSF in San Francisco of 335 patients. These cohorts are actually quite different from each other in terms of demographics, race, ethnicity, severity of illness, and outcomes, but both represent diverse observational cohorts of patients that are, in many cases, excluded from randomized controlled trials. We used similar clinical and biomarker variables as prior latent class analyses and performed de novo latent class analysis in each cohort, finding that a two-class model was indeed the best fit for the data, much like our randomized controlled trial studies, and that these two classes seem to be prevalent in both cohorts in similar proportions to our prior RCT-based studies. This slide shows the continuous variables that were used to define the phenotypes and comparing the hyperinflammatory phenotype here in yellow to the hypoinflammatory phenotype here in blue. And you can see that the features of these phenotypes with high levels of plasma, with the high levels in the hyperinflammatory cohort, I should say, of plasma inflammatory biomarkers like IL-8, IL-6, and TNFR1, and low levels of protein C, bicarbonate, and platelets are quite similar to those that we have observed in randomized controlled trials. In both cohorts, clinical outcomes widely diverge by phenotype, with the hyperinflammatory group having many fewer ventilator-free days and significantly higher in-hospital mortality. So the take-home point from this data is that ARDS phenotypes do not seem to be confined to randomized controlled trials. What about feasibility? Can we practically identify these latent phenotypes? Well, this is something our group has been working on for quite some time, again, in work led by Dr. Sinha, my former postdoctoral fellow, with the idea that using 35 plus variables to identify a patient and latent class analysis is not possible at the bedside. So how can we use a smaller set of variables to identify these phenotypes? What Dr. Sinha did was to derive models in a combined cohort of over 2,000 patients derived from 3 of the large clinical trials in ARDS in which we'd identified these phenotypes, and then validate those models in 3 independent ARDS cohorts. What I'm showing you here is the data we published in the largest validation cohort, which was the sales cohort of 745 patients. And what you can see here is that either a 3-variable model of IL-8, bicarbonate, and protein C, or a 4-variable model that adds vasopressors, both performed quite well in terms of classifying the phenotypes, with areas under the curve of 0.94 or to 0.95 in comparison to phenotype by latent class analysis. Actually, multiple models performed quite well. If you take the top 6 variables for classifying the phenotypes shown on the screen here, you can see that various combinations of 3 or 4 of these biomarkers all performed quite well for classifying phenotypes in the independent validation cohort. What we published more recently last year was actually testing this out prospectively with a novel point of care assay in 39 patients with COVID-19 ARDS. This was a collaboration between our group and Danny McCauley's group in Northern Ireland, with great input from Tomas Sakmani, University of Cardiff, in which we enrolled 39 patients with COVID-19 ARDS and actually prospectively classified them using this novel point of care assay and the parsimonious models that I showed you on the prior slides. We performed real-time measurement of IL-6, TNFR1, and bicarbonate and assigned patients in real time to one or the other phenotype, with the local sites kept blinded to phenotype assignment. What we found is that using this parsimonious model, and the cut point from the prior study I showed you is that only about 1 in 5 patients with COVID-19 ARDS actually fell into this hyperinflammatory group. That group had a significantly higher mortality compared to the hypoinflammatory group. Now, this is a very small sample size, so further validation of the actual prevalence of these phenotypes in COVID-19, as well as discussion of, frankly, whether these are the best phenotypes for COVID-19 will be needed. But I think what it demonstrates is that real-time phenotype classification is going to be likely feasible, though we still need more widespread availability of these point-of-care assays. All right, now let's talk about specificity. Are these really phenotypes of ARDS, or are they actually phenotypes of critical illness more broadly? Now, this group out of Pittsburgh, led by George Kitsios, Brian McVary, Allison Morris, and others, published data in Critical Care Medicine in 2019, indicating that phenotypes similar to those that we had described in ARDS are actually present also in patients at risk for ARDS. What you see here in the figure is that both when they used latent class analysis and the parsimonious model that we had described in our earlier work, they were able to identify patients with the hypo and hyperinflammatory subphenotypes in patients who were at risk for ARDS, as well as those who actually qualified as having ARDS. This was important external replication of both the latent class analysis findings as well as the classifier model, but really an important paper, I think, because it indicated that these phenotypes are likely not confined to patients who meet the syndromic definition of ARDS. A new paper has just come out earlier this year, actually, from Lua Boss and Nanan Haidjan, that had a similar, but actually potentially more impactful finding in mechanically ventilated patients without ARDS. What this group found is that both their cluster-derived reactive and uninflamed phenotypes and the LCA-derived phenotypes are associated with mortality in mechanically ventilated patients without ARDS. And this study had a much larger sample size than the prior study. What you can see here from the table at the bottom is that both the reactive subphenotype and the hyperinflammatory subphenotype were associated with mortality, not just in univariable analysis, but also in multivariable analysis that controlled for age, gender, and Apache score. So this finding really suggests that these phenotypes may not, in fact, be unique to ARDS alone. This figure comes from a review, an editorial, I should say, that Kiran Reddy, Danny McCauley, and I wrote on the paper I just showed you that suggests that in critical care, we might be moving towards a new paradigm in which patients may no longer be classified by their syndromic definition for all purposes, but might actually be thought of as having specific treatable traits that may be present within syndromes like ARDS, sepsis, or respiratory failure, and that there may be actually quite a bit of heterogeneity in these traits within the syndromes. Now, the extent to which these phenotypes are present in other diagnoses like sepsis and acute kidney injury remains unknown. Similarly, the overlap with the well-described transcriptomic phenotypes of sepsis, of which there are, of course, multiple approaches, is also unknown. And as I mentioned earlier, the best approach to phenotyping may be very different depending on the specific agent that's under study. So I think this area of specificity of phenotypes is really an exciting one in which we need much more data. All right, let's talk about another area in which we need more data, and that's mechanism. So these phenotypes, the latent phenotypes that we've described, have been termed hyper and hypoinflammatory, and I, in some ways, really regret letting those terms be applied to them because it's not really clear that inflammation is in fact the driving mechanistic difference. We suspect that it's inflammation because the biomarkers of some biomarkers of inflammation are higher in this hyperinflammatory group in the plasma. But might it be some other mechanism? Might it be endothelial injury, right? We've assumed that the reason that we see this differential treatment response to, for instance, simvastatin is related to inflammation, but it's certainly not confirmed. And I think we have to be very careful about presuming mechanism from really superficial biologic analyses. And this work by Nuala Meyer, published a couple of years ago in Critical Care Medicine, provides an important cautionary tale to this angle. What Dr. Meyer did was to reanalyze data from the original anakinra trial in sepsis. And she had the interesting hypothesis that the mortality benefit of recombinant human IL-1RA or anakinra in sepsis might vary based on the initial IL-1RA plasma concentration. And I think if we were going to think about this ahead of time, we would say, well, maybe if you have low endogenous IL-1RA, which is an anti-inflammatory or thought to be an anti-inflammatory agent, that you would benefit from getting additional exogenous IL-1RA. And what Dr. Meyer found was that there was indeed, there did seem to be a differential treatment response based on the endogenous plasma IL-1RA levels, but it was actually the opposite of what you might imagine, in that those patients who had low plasma IL-1RA seemed to do worse when given exogenous recombinant IL-1RA, and the opposite in the patients who had high endogenous levels. Those were actually the ones who seemed to benefit. So let's just do a thought experiment here and imagine what if you had done the clinical trial targeting only the IL-1RA low patients shown here in the blue. Well, what you might have seen if this analysis is actually correct is a harmful effect. So I think we have to be really humble about the biologic complexity that we face here and work hard on studies in a translational setting that actually attempt to understand mechanism on a deeper level. All right. So last but not least, what about approach? How should we think about incorporating phenotypes into trials? Well, this could really be its own whole separate talk. So I'm only going to have the time to touch on this very superficially. But I think if nothing else, we need to think about phenotypes ahead of time. The approach that takes the least effort and is also the least efficient is to do a pre-specified subgroup analysis in which in a clinical trial, we think ahead of time, okay, well, maybe I want to account for phenotype and plan a subgroup analysis. I think we have to be extremely careful about trials that focus only on one phenotype. Witness the example that I just showed you of IL-1RA, where I think we could very easily get ourselves into trouble. So how do we proceed with a somewhat incomplete understanding of mechanism at this point? Well, I think if we think about adaptive trials with phenotype-based stratification, that could potentially allow us to really learn as we go and enable unexpected discoveries. And this approach is already being implemented in breast cancer, asthma, and in many other settings. Our group is working to take lessons translated from the oncology world in the I-SPY 2 trial, which was really the original paradigmatic adaptive clinical trial, into the critical care arena with the I-SPY COVID trial, which is currently happening at sites across the United States. Now, this trial is not currently adapting based on phenotype, but our goal is ultimately to move towards an adaptive biomarker stratified clinical trial design in ARDS that would allow us to account for phenotype while also remaining humble about that biologic complexity and learning from the data as we go forward. So in summary, we've identified these two latent phenotypes within ARDS in 5 randomized controlled trials that have differential responses to ventilation, fluids, and pharmacotherapy. I think there's pretty compelling evidence now that these phenotypes are present in observational ARDS cohorts and likely in patients at risk for ARDS. I think bedside identification may be feasible quite soon. However, the driving mechanistic differences between these phenotypes are not entirely clear. We have to really remain humble about the biologic complexity that underlies these. Adaptive trials may allow us to learn as we go which treatments work best for which phenotype, and really also which phenotyping strategies are the best for the particular drug that we're interested in studying, because it probably is not one size fits all. And above all, we need to think about prospective confirmation of phenotypes and of differential treatment responses before patient care should be effective. Thanks very much.